Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Today, we're joined by Lennie Shewmaker McDaniel, the director of ACR's DC office and the director of Congressional Affairs. She provides a critical update on the evolving legislative landscape and the battles shaping the future of rheumatology. From the steep Medicare reimbursement cuts that are putting practices underwater, to the ongoing struggle with pharmacy benefit managers and the uncertain future of research funding, Lennie offers a frontline perspective on what it takes to advocate for our patients and our profession on Capitol Hill. Lennie brings her extensive experience in public policy, having served as healthcare legislative staff for a House Majority Leader, represented healthcare clients at a private government relations firm, and managed a political action committee for over 60 members of Congress. Lennie is a member of the State Bar of Georgia and holds degrees in political science and writing from Birmingham Southern College, as well as a Juris Doctor from the University of Georgia School of Law. Enjoy. Lennie, welcome back to the show.
Thank you so much. It's been a busy year.
You could say that again. Anything new in Washington over the last few months?
What isn't new is more.
Yeah. So Lennie, it's always great to speak with you about advocacy and sort of some of the congressional issues that are going on that may affect rheumatologists. And we've invited you a couple of times. And for today's episode, we wanted to sort of get a sense of what are some of the issues that the ACR is actively pursuing in terms of advocacy, trying to improve the lives of our patients and our members, the rheumatologists that care for them. I wanted to start with Medicare reimbursements. This has been sort of a very contentious topic. It is my understanding that there will be planned Medicare reimbursement cuts to rheumatologists in the future. And I was hoping that you can shed some light about, what this may mean for rheumatologists. What's going on with these Medicare reimbursement cuts?
Sure. So unfortunately for our members and for all physicians really that accept Medicare patients, there's kind of been a systematic annual cut to reimbursements for treating Medicare patients. A lot of this is due to a balanced budget requirement, which says that any single time that there is an adjustment to any one reimbursement for a service or a procedure, then that the money to balance out that increase has to be cut from elsewhere in the Medicare physician kind of pot. So that cut usually comes from the conversion factor, which is the multiplier that all physician payments use, and therefore kind of reduces the pay for all Medicare payments annually. The ACR has advocated for a long time to reduce or to take away the balanced budget requirement. Obviously, that's an incredibly expensive suggestion. It is our stance that physicians should get paid the cost of providing care to patients. I think that philosophy certainly lands with policymakers.
Sure.
I think the price tag of that is a really difficult road to hoe. So we're going to have to deal with more incremental changes. So what's happening is, in addition to everything else, the physician fee schedule, as opposed to the hospital fee schedule or the other Medicare fee schedules, is also the only one that isn't updated for inflation. One of the more jarring statistics is, I think the current conversion factor is $32.74, so $32.74. And if it had been adjusted for inflation each year since its implementation, it would be $67.39.
Oh my goodness.
Yeah. So physicians really missed the boat with getting their reimbursement attached to inflation. So another thing that we've really been advocating for is attaching that number to some version of inflation. So the last cut was January 1st. It was 2.83%. And one of the other problems is each time these cuts are implemented, they sound very small. And to have physicians come to Congress and say, we can't take a 1.3% hit, we can't take a 2.4% hit, was really difficult in the beginning. And now that it's cumulatively gotten so big, it's a much easier argument. But the problem is now that it's cumulatively gotten so big, it's also put physicians in a lot of practices underwater, where treating a Medicare patient truly costs more than they are reimbursed. So it's a huge problem, especially for rheumatologists where the margins are particularly thin anyway. The good news is, as of last week, when we were meeting with the DOT caucus, which is the GOP physicians in Congress who have their own official group, and this year are in the majority and therefore a big part of policymaking, they have worked on a piece of policy that's currently in the Energy and Commerce reconciliation package. Reconciliation is not a legislative package that is required to pass. It's a kind of legislation, or a kind of style of making legislation. So when I say reconciliation package, it just means that it's only going to take 51 votes to pass the Senate. But they're in the budget making process is essentially what I'm saying. And in the Energy and Commerce Committee budget, there is a piece of verbiage that would create a singular conversion factor starting in 2026 versus we have two now, one for physicians that are using alternative payment models and one for physicians who are not. So there would be a singular conversion factor starting in 2026 that is actually tied to the Medicare Economic Index, which is the index that gauges inflation. And for 2026 and 2027, at least, there would be inflation updates. We don't really know what would happen in 2028. Nothing in the package really addresses what happens after 2028. That's a precipitous drop off. Obviously, that would be the end of the current administration, and no one's really planning for after that. But that is a very hopeful measure that is currently in this package that is moving, which is that Congress is actually planning to do something, certainly sees that this is a big issue and is writing legislation into place. And the fact that it's not just a one-time fix, but is a tie to inflation that could set up that is a regular accepted solution as opposed to just a one-time bump, but that tying it to inflation could become something we can ask for without sounding crazy is certainly helpful. So we're pretty early in the budget making process, but that's certainly a really encouraging thing that we're seeing.
So let me get this straight, just so I understand it. It sounds like over the last few years, physicians are inflation adjusted, getting reimbursed half of the amount that they used to when seeing Medicare patients. That is huge.
Yes.
And I wonder, what does that mean for both rheumatologists and patients that, rheumatologists are getting paid half as much? Does that mean that we need to see twice as many patients to sort of come up even? Patients need to have their appointments shortened by half, or are there just going to be less rheumatologists and less people willing to care for Medicare patients?
I would say, unfortunately, all of the above. I think we've seen a lot of different adjustments to this. At the end of the day, physicians need to work with reliable business partners, and Medicare more and more is not being seen as a reliable partner in business. And therefore, physicians in private practice are having to see more private payer patients to offset the number of Medicare patients that they're seeing and scaling way back on Medicare patients. Since 2012, we've seen a huge increase in the number of physicians who are private practice physicians who just don't see Medicare patients, which is an option. There's certainly no requirement. And that's going to be a huge hit to the Medicare program if that's the way this goes. But like I said, if you are in a capitalist system and you have an unreliable business partner and a small business, I see how that decision gets made. But we're also seeing an increase overall in small practice owners selling to hospitals, selling to other larger businesses, or pivoting out of practice in general and going into other aspects of the healthcare industry, citing things like burnout. And burnout means a lot of things, but one of the things that we know contributes to burnout is not feeling like you are being compensated for the amount of effort that you are putting in. And one of those things is you're not making the overhead, you're not being able to pay enough staff. And if Medicare isn't reimbursing you the cost of seeing patients, that certainly can contribute. So unfortunately, I think that this is contributing to what we're seeing also with the workforce issues and the burnout. And we think that if we could see massive change in the Medicare reimbursement structure, I think we would see a lot of downstream effects with a lot of the other issues we're seeing.
Yeah, we've spoken also about the workforce shortage that, there's a increased demand for rheumatology services, decreased supply of rheumatologists, and these changes are only going to make that even worse with physicians either opting out of seeing Medicare patients or closing up their practices or doing a lot of things that are not for the benefit of patients. That's really sad. And I'm glad that the ACR is trying to do something to fix this issue. I wonder, how do other insurance companies sort of agree with compensation? Do they look at Medicare reimbursements and try to sort of more or less match what Medicare is doing, or are they completely separate?
Yeah, that's part of the problem as well, is unfortunately Medicare sets the tone for the entire market. So this artificial suppression of reimbursements by Medicare because of the balanced budget requirement has artificially suppressed reimbursements for physicians across the board. And it specifically impacts rheumatologists more than, say, a proceduralist, because proceduralists have their codes reevaluated on a more frequent schedule, which is seemingly benign and is certainly not purposefully punitive to rheumatologists, but just because it's on a more regular schedule, it means that they get readjusted more often. And be due to their readjustments, the CF gets cut more often. And if the conversion factor is getting cut more often, then it is the non-proceduralists who are suffering those cuts. And therefore, in-office care, evaluation and management codes, which is what the rheumatologists use most often, are the ones getting those cuts. And we did get a couple pretty sizable readjustments in the last couple of years. So I don't want to act like rheumatology doesn't get their adjustments, but the reason those adjustments were of note is because it happens for us so rarely, because our schedule is so much fewer and further between than the procedural schedule. So it was after many, many years of cuts to in-office codes that it finally became the in-office code's turn to be evaluated for more appropriate compensation. So even just by the nature of when the specific codes are being evaluated within this system, rheumatologists and other in-office care providers are being kind of put at the bottom and suffering. So this also feeds into the private payer model for reimbursement. So it's a bad cycle. And unfortunately, Medicaid sets their prices based on Medicare, private payers set their prices based on Medicare. So if we could get the balanced budget requirement eventually repealed, that would change the game. And this is, I think that one of the things that's important for people to understand and for our members to understand, the ACR is pretty agnostic about, we're obviously very bipartisan and agnostic about the stances of the legislators that we speak to. So if we're in an office where the member is, say, a huge proponent of Medicare for all, one of the things that we're going to say to them is, if that's what you would like to see for this country, the first thing that needs to happen is Medicare currently needs to start working. And in order for the current Medicare system to work, the balanced budget requirement has to be repealed. And physicians working in the current Medicare system need to see it as a reliable business partner. Here's how we could get to there. And then when we see another kind of office that maybe sees Medicare as a program that they don't want to see grow at all, it's like, well, at some point you chose a capitalist system, and if we're going to have a capitalist healthcare system, then people who own a small business like a physician practice have earned the right to charge what it costs to provide this service. So it's important to understand that there is no view of this where the ability to charge what it costs to treat a patient isn't the correct route.
Correct. And is the ACR going at this alone, or are you working with other physician organizations to try to get these adjustments made by Congress?
Yeah. So the overall, repealing the balanced budget requirement obviously is a long-term fight that we're having. And that is a big, massive, all of the physicians in the country, we know that it'll be a long one, but we all agree on that one. Tying physician reimbursement to inflation is obviously also a big, huge fight, and that is shared with all the physicians in the country. The AMA made this a big issue in their February fly-in and had a physician rally on the Hill. Lots of images of people in white coats flooding the Hill. We were there. It was a part of their legislative conference that we were a part of because it was right after the inauguration and the new Congress being sworn in. So we certainly wanted to attend that and get a read on what the AMA's legislative priorities for 2025 were. But they made that a cornerstone of their legislative priorities this year. So we do feel like we are certainly not alone in these arguments. But when we do get into the nitty gritty of the current structure and fighting for our piece of the pie as it is like kind of currently laid out in this kind of gladiatorial system of if one code is readjusted, everyone else must suffer. Then, of course, the specialties do unfortunately get pitted against each other, which is something that then kind of divides us into in-office care versus proceduralists. And unfortunately, our coalition of medical specialties then has to subdivide into more nuanced groups as we work on those issues.
Super interesting. So it's like, instead of trying to make the pie bigger, it's a sort of a zero-sum game, right? If somebody gains, then somebody else needs to lose. It doesn't seem like a great system. And I'm glad the ACR and other organizations like the AMA are fighting against that. Let's now discuss another favorite topic is the PBMs, the pharmacy benefit managers. We've spoken about PBMs before in this show, but why don't you remind our listeners what they are and what problems they bring with them?
Sure. So essentially, a pharmacy benefit manager originally was created to be a consultant type organization. They were created to consult with private payers to create formularies for those private payers and to negotiate those prices and help create those formularies and then negotiate with the pharmacists or the pharmacies to provide those drugs. At this point, it's become a $500 billion business.
Wow.
Yeah, it's very regularly ranked as the most profitable businesses on Forbes lists. The vertical integration is shocking at this point. Insurers are very often investing in pharmacies because they own a PBM and then a pharmacy. And if they can just own every single piece, why wouldn't they? Because I think they were realizing how much money they were spending on PBMs and then buying down the line, which if that's where all of my money was going, I'd, probably buy one too. But when $500 billion is being sucked out of the healthcare system, but physicians can't afford to see, physicians aren't even getting reimbursed the cost of seeing a patient. Like our system can't afford that. And I think it's really important to remind everybody that pharmacy benefit managers do not see patients. They do not create a product. They have no fiduciary obligation to any client. So
they're just middlemen, right?
They're just
And
middlemen.
they take a cut of prescription drugs. Is that right?
And my understanding, I'm obviously not a rheumatologist. I just hear from you guys and try and represent your interests as much as possible. But one of the complaints that I'm constantly hearing is that formularies change quarterly. And so it's not even like they're contributing to a consistent, reliable system where sure, things are more expensive than they need to be, but at least we all know what's going on and can read the room. Like it seems like chaos. So I think one of the problems that they're suffering from, and they're suffering from a lot of image problems, is that there's nothing about them that anyone can point to that's doing anybody any great good. And so one of the things that we know for sure that they're doing is driving up the cost of treatments. They're negotiating a lot of rebates and clawing back the difference in copays, essentially a lot of discounts, rebates, copays, however you want to phrase the discounts that they're negotiating. In a lot of different contexts, they're keeping that money for themselves as opposed to making sure that either the patient or the plan provider, whether that be an employer or whoever that entity is, gets that discount. So one of the things the ACR has always supported is delinking, quote unquote. These are all like beltway terms, but we call them delinking provisions. But basically, it's disconnecting PBM income from any profits for themselves they've negotiated or discounts they've negotiated, or and making them standardizing their income as a service fee based income or negotiated contract with. If you are negotiating a formulary for a private payer, then negotiate a contract like any other consultant and get paid that contract fee, as opposed to linking it to the price of the drugs you're negotiating. We think that that will lessen the impact on the cost of the treatments going up. So that's one of the things that we've certainly always supported. And then the other thing is requiring that any of the discounts negotiated, we would love for them to have to go back all the way to the patient, but at the very least to go back to the plan providers so that they can reduce the costs of the plans so that it eventually gets to the patients. We have seen, again, this is all in energy and commerce for some reason. I mean, I know why, because that's the jurisdiction of the committees, but I just, for the listeners, why I keep saying energy and commerce, but in the energy and commerce budget, again, with our Medicare reimbursement, there is a PBM section in that bill, which is very encouraging. And I'll tell you why. It's because PBMs also negotiate formularies for Medicare and Medicaid programs. And this is an area where they can find what we call pay-fors, which means if it's an area where Medicare and Medicaid can save money, then those savings will cover the cost of other provisions like Medicare reimbursement provisions. So the PBM policies that we're seeing in that bill right now are actually a delinking provision that would limit PBM income to what they're calling, quote unquote, bona fide service fees. So that would remove the ability of PBMs in Medicare Part D from linking their income to the negotiated cost of the treatments that they've negotiated within their Medicare. And then the other thing that is in that bill is there's another PBM provision.
It's pretty crazy what's going on, sort of like in our offices. This idea that biosimilars will end up being a cost-saving measure, but because of PBMs and all the rebates. I just had a patient last week who was on, brand name Humira, and their insurance required them to switch to a biosimilar. But for the patient, the out-of-pocket costs of switching to a biosimilar went up because of copays. So even though somebody's, I'm sure, making money because these biosimilars are theoretically cheaper, that's not translating to lower costs for the actual patient. They're actually having to pay more. I think her copay was like $400 a month for a biosimilar. And it's pretty nutty to think that somebody's making a lot of money and the patient is bearing all of the cost. It's ridiculous.
100%. And on April 8th, actually, the Health Subcommittee of the Ways and Means Committee held a hearing called Lowering Costs for Patients, the Health of the Biosimilar Market. And a member of our board of directors, Colin Edgerton, actually testified. And one of the things he really focused on was the underwater biosimilars situation, and that PBMs had largely created, which was that because of the way that they negotiated formularies, et cetera, the saturation of the market by the new biosimilars that were intended to, of course, lower prices had not had the effect that they hoped that they would have. And I think that the other provision that I was talking about for in the Energy and Commerce bill would help that, which is that they are requiring, or would require if it passes, transparency for drug formulary decisions and coverage benefits for any transparency around those decisions, but then also any coverage benefits that benefit any pharmacies affiliated with PBMs. So like I said, with all of the vertical integration that's happened, there's been a lot of questions around the affiliated pharmacies with the PBMs. And so now any negotiated prices or any contracts that specifically benefit pharmacies that are affiliated with specific PBMs would have to be disclosed publicly. So I think all of these links in the chain, making those public and clarifying and increasing transparency around formulary decisions would all be very enlightening for how these things kind of aren't happening. We know that at least for the biosimilars, there's also a glitch in the ASP where some of the rebates that are being negotiated for biosimilars to get them on formularies are then being included in the ASP formulary. So for doctors who do buy and bill, they're buying at the market price and then being reimbursed at this ASP that's included rebates. And so again, it's a matter of being reimbursed a much lower cost than they've actually paid out of pocket. And so that's an
Wow.
issue we're also trying to work on. We're aware of, just in case anybody listening is as we've gone down this biosimilar tangent, but we have an underwater biosimilars coalition that we've sent a few letters on. If anybody, rheumatology.org/letters to policymakers, you can look through all of the communications we've sent on all of these various topics.
Awesome. Super important. Wanted to talk a little bit about, some of these efforts that the ACR is doing. I think the sort of the channel through which a lot of these policies go through is RoomPAC, the Political Action Committee. Can you talk a little bit more about sort of what RoomPAC is and provide some updates about fundraising and one of, the accomplishments of RoomPAC?
Yeah, so we rely on the PAC a lot. RoomPAC is the only federal political action committee that is solely focused on rheumatology issues. It's incredibly important for what we do, but it's very small. So for how much we rely on it, it's shocking how much we're able to get done considering the size of our membership and then the subset of our membership that actually participates in RoomPAC. So we would love to grow it. So far
Hint
this
for
year,
listeners out there. You're an
yeah,
investor
we
in
would
RoomPAC.
love, please, rheumpac.org, RHEUMPAC.org. So, for example, we've done, I believe, 23 PAC events this year. The difference between a Hill meeting and a PAC event. So, we've also done 130 plus Hill meetings. So,
Wow.
we are certainly not saying that Hill meetings are not valuable. We do them all the time. But a Hill meeting, there's a specific office I need to get into, and I need to have a discussion with that office. So let's say it's like we've talked about energy and commerce a lot. So I'm going to need to get into energy and commerce to talk to them about the specific provision in this big package that's being built. So I make contact with that office. I get in contact with the health staffer that I know I need to talk to. I get in there. I talk to them for 15 minutes about the exact provision we need to discuss. Make sure that they know where ACR stands on it. I offer our help. I offer our resources. I make sure I get a read of where they are on that provision. We have a very policy deep conversation about where they are on it. And, it's very peer to peer. I was a healthcare staffer for a little bit. So we just have this discussion and then I'm out. That's why we've done 130 of them versus like 22 of the or 23 of the PAC events. But a PAC event is me and that person's boss. And we do mainly almost entirely just healthcare specific PAC events. So it will be me and say 7 to 10 other medical specialty lobbyists at dinner with that staffer's boss. And it will be hours of healthcare specific conversation. And we are able to branch much further out from the policy that I talked to that staffer about into the philosophical needs of the constituents, into, like we were just talking about, what can be done in this exact package. But we also talked about the broader need for repealing the balanced budget requirement and how long that would take and why it's needed and the history of it. Those are the conversations we can have with these members of Congress if we have the space and, a glass of wine and the right audience and 10 people and the bell can't be rung for both votes. So it's just really important to create the runway and the context for education and relationship building in those areas. It is bipartisan. We recalibrate our assessment of how to invest those funds with each Congress to make sure that we're really being as strategic as we can possibly be. So, I think it's such a good tool in our tool belt. And like I said, like this year, we've found it very valuable to just do healthcare specific events. It doesn't really do us a lot of good. I think a lot of industries are doing this because everybody feels like there's so much change going on that they don't need to really listen to general conversations. We really just need to be honed in on our own topics. So far this year, we've raised $41,000 from 145 contributors, which is actually a great year for us. But again, that's 145 contributors carrying the weight of the entire rheumatology community, because this, like I said, is the only PAC focused on rheumatology issues. So while those 145 contributors are setting records for us, it's also 145 people doing the work for everyone we are so appreciative. So the average contribution is about $300, which is a little high for normal. So that means that our highest donors are coming in early. I think probably because there's so much going on this year that they they immediately saw
They
the
want to
need.
do something.
Yeah, they saw the need early on and wanted to take action. But we've dispersed over $30,000 already this year, because we know that
Mm,
there's a lot of conversations that needed to happen, and we needed to be at these events and have these conversations. And so
mm.
we're spending it as we're making it, because we certainly don't want to, as these policies are in development, we don't want to leave any tools in the tool belt while these huge decisions are being made. We can't limit ourselves when we're trying to represent the members of ACR and ARP as effectively as possible.
Got it. Yeah. So again, another plug to be an investor in RoomPack, and we can have, all of these links in our show notes. And for trainees also, if you could invest, $5, that would go a long way.
Also, we allow access to the Room Pack Lounge at
Mm,
Convergence for
mm.
any donor. So, a very cheap way to find a place to rest and hang out at Convergence if you're going to be there.
Yeah, and you get cookies and drinks. It's
Uh
great.
huh. And a place to store your luggage on the last day.
Lennie, there's been a lot of discussions about research funding, especially through the NIH, and we won't have time to go through that today. But, the government funds research in various other ways. I'm wondering if you can talk a little bit about rheumatology related funding through the Department of Defense and what has been going on with that and what the ACR is doing about it.
Yeah, so I definitely wanted to talk about this. We fought for almost a decade to get the arthritis research program off the ground in the Department of Defense. A lot of people don't know this, but arthritis is the leading cause of medical discharge for service members, second
Mm,
only to battlefield wounds. The way that service members train and the physicality of that profession causes a lot of specifically osteoarthritis, but we also see larger instances or increased instances of rheumatic arthritis in that population, which is very surprising because of the differences in the age and the health and the activity of that population versus the civilian population. It's really important that the research be specific to these service members. Also, the DoD is a closed loop system, so everyone has a physical upon entry, a blood
mm.
draw upon entry. They get those on a regular basis. All of that data is kept within that system and can be used at any time. They've all signed waivers for that access. So it's a great place to have a research program, between the impact on the population and then the situational availability of getting data. It just is a perfect storm to be able to help these service members and reduce the impact of arthritis on these kind of essentially forced retirements that is medical discharge. When you receive a medical discharge due to arthritis, it's not because you wanted to retire. Dr. Colin Edgerton was actually a rheumatologist in the Army for 12 years and came to us a long time ago talking about how his primary job he has a Bronze Star, so it's certainly not all that he did, but one of his primary jobs was signing off on all these medical discharges for people leaving the service due to arthritis. So we
Mm.
eventually got this arthritis research program off the ground to, increase readiness for our armed services and decrease the impact of arthritis for these service members. And unfortunately, in the March continuing resolution, this research program lost all of its funding.
Oh,
I think there was a lot of moving parts in that budget. And I don't think there was a lot necessarily of thought put into what was going on. And so we've tried to do some education on the Hill about why this was such a crucial program and why we need that funding to be reinstated. So we took this to the Hill on May 6th. We're filling out all of the appropriations requests to get that money back. But I think that it's in the sea of all of the other research that's going on, something I did not want to get lost in the shuffle, how important this is for our service members, how specific this program is, and how crucial it is, especially to the administration's goals as they focus on growing our services and increasing readiness and focus on our armed forces, that keeping our armed forces as they currently exist ready and healthy and
Hmm.
not having arthritis related discharges is certainly a good place to
Wow.
start. So,
Very important. Talking more about cuts, the HHS, the U.S. Department of Health and Human Services, has announced significant reorganizations, as they call it. This is the department led by RFK Jr. I'm wondering if you could provide us with some highlights of this reorganization and why it matters to patients and rheumatologists.
yeah. So there's a lot of moving parts to this. We are certainly not emotionally attached to the current structure of the NIH. We don't think it's flawless, but the swift shifting sands have not allowed for a lot of assessment as to what these changes are going to be. So we're trying to be as responsive as we can be and offer as much guidance as we can as to what we'd like to see. So far, we've seen the jobs cuts that I know everyone has seen in the news. But in addition to that, there have been 3 divisions within the CDC that impact rheumatology that we have seen dissolved, and we are still unsure as to what that means for the programs and research within those divisions. So we wrote letters to Congress, but also to HHS, one set of letters with the Arthritis Foundation and one set of letters with the Lupus Foundation of America about those divisions. It was the epidemiology and surveillance branch, which covers all of the lupus programming, and then the healthy aging branch, which covered all of the arthritis programming. So we wanted to communicate with them, basically reinforcing the value of all of those programs and then asking where they would be housed, if they would still be fully funded, kind of what the future of that programming and research is. Because what's happening is HHS did announce that they were going to reduce the current divisions of the FDA, the NIH, and the CDC from 28 divisions down to 15. So we knew that this kind of consolidation was happening, but also on Monday, the CDC was one thing. And then on Tuesday, these 3 divisions were gone. And there isn't really a lot of guidance or information out there as to like what happens, like I said, with the programs or research therein. So then when we got rumors or kind of there was a leaked document implying some shifts and changes at NIH that would impact the NIAMS program, we wanted to be much more forward or more, just much more active about communicating on the front end. So we sent a letter to HHS immediately about that program, the value of NIAMS, what we would like to see in any sort of restructuring of NIAMS, or if it is going to be consolidated into any sort of new grouping with other institutes, the activities that it currently engages in and the research it currently does that we want to make sure is preserved, and the aspects of NIAMS that are currently in place that we want to make sure continue. So yeah, there's a lot of shifting sands over there that we are keeping an eye on, but we sent that letter on the future of NIAMS to the HHS secretary. We also signed a Friend of NIAMS coalition letter regarding continued funding for that institute. We also have continued to send all of our normal letters just about the funding for NIH and research in general. Also, investing in research and the value of research was one of our top Hill Day topics on May 6th. And again, this is back to making sure that we're tailoring our message to everyone. I think that one of the things that gets lost, especially in our membership who's so close to the topic, and it's to them it's so science oriented, it's so patient oriented, it's so discoveries oriented. But if you step back from those priorities, this is also an economic issue. A recent study that came out in April showed that a 25% cut to public research and development for America would result in a 3.8% reduction to the GDP, which is the equivalent of the Great Recession.
Wow.
And, as we all know, $1 of NIH funding in your community results in $2 of economic development. And these aren't if your research creates a breakthrough. This is just doing research within your community. So I think these are the messages we wanted to make sure we got to specific offices that maybe aren't as invested in in the more philosophical ideas behind all of it, but to understand the economic impact. And that this is also a huge part of our economy. This is a huge part of the way in which America functions as the business of America and the way that scientists are employed in this country and the way that we function as communities. And so one of the reasons why this has not been a big issue for ACR previously is because every state in this country has a research institution in it. And so previously, this has just not been an issue that legislators have touched on because everyone feels very protective of those institutes. So it's been good to be able to go in and talk to legislators and remind them how important these institutes are, how many people they employ, how it impacts their communities, their economies. And then obviously, as the representatives of ACR and ARP and the patient population, the research that they actually do and the discoveries and publicly funded research goes down researchers' hypotheses that private payers and private research will not explore until there's a potential profit. And so that's
Right.
incredibly important to us philosophically, but we also make sure, or we understand that that argument is not as important to every office. So we made sure that when taking it to the Hill that we hit everybody's priorities.
Makes a lot of sense. Sounds like very challenging times indeed. And then the last topic that I wanted to discuss with you, Lennie, is Medicaid. So, as we all know, Medicaid is this joint federal and state program that provides health insurance to people with limited income and resources like low-income children, families, seniors, and people with disabilities. And I understand that there's also a proposed Medicaid cuts. How does the ACR see those cuts?
Yeah, and this has just come back in the news actually because initially, so the House's goal with this bill that we've been talking about is to cut 1.5 trillion from the budget. The Senate has a much smaller goal. So one of the things that the Energy and Commerce Committee did is actually they only ended up they were tasked with cutting 880 billion from Medicaid. And their bill actually only cut 715 billion. And now there's some discussion as to whether or not that's enough. It's a topic that's in the news. We certainly don't want to pretend that it's not a thing that's being discussed. And it's not the huge policy point that's going back and forth in DC and a huge policy point that impacts healthcare. The ACR obviously supports access to care for our patients. ACR members get paid by Medicaid. That's how a lot of our juvenile arthritis patients are covered. We are supportive of access to care by, there's 83 million members of the American public currently covered by Medicaid, and we are not
Wow.
we're not supportive of measures that would reduce the access to care for American patients currently relying on that program. So we have been doing some education on this topic. I think one of the things that's really important for legislators to understand is the impact of Medicaid on Medicare and the number of dually eligible patients out there that rely on Medicaid to fill in the gaps of Medicare, and how many of them rely on Medicaid for things like dental coverage, and it helps them pay their Medicare premiums. It covers their coinsurance or copays. Especially for low income or like things like the extra help program. So I think that especially where people think of rheumatology as a Medicare specific specialty, Medicaid helps Medicare patients. And so a lot of what we do when we interact with Medicaid is Medicare specific. And then our pediatric rheumatologists have long advocated to us to protect Medicaid. And I think that 40% of America's children are already disproportionately affected by the medical workforce shortage. And there are multiple states in the country that currently don't have a pediatric rheumatologist. I believe that count is 7. At least one of them, Montana, we have a pediatric rheumatologist who's just waiting on her board results. So
Wow.
don't worry, one's coming for you. But for pediatric rheumatologists, Medicaid reimbursement is a huge issue. One of the reasons that being a pediatric rheumatologist is so difficult and that there's such a shortage is because Medicaid reimbursement is incredibly low as it is. And being a pediatric subspecialist or specialist requires extra training for both pediatrics, but then extra training also for your specialty. So you've had more years without the income of being a professional and more years of training. And then when you come out of that, you're going to get paid less because Medicaid reimbursement is actually lower than Medicare reimbursement and is the basis on which private payers are going to base your pay. So we're certainly afraid that cuts to the Medicaid program could impact that already tenuous relationship between access to care for juvenile arthritis patients and our already pretty dire pediatric rheumatology workforce situation.
Absolutely. I mean, I think I was talking with some pediatric rheumatology program directors this week. About half of the spots for pediatric rheumatology fellows went unfilled this year. And you're absolutely right. Residents are smart and they're saying, well, why would I want to train for longer to get paid less than just going out and starting to practice. So these cuts to Medicaid have a huge implication into the workforce, right? And the future of pediatric rheumatology. So I'm so thankful for you and for the ACR that you guys are aware of these issues and are doing your hardest to try to prevent these cuts from happening that can harm, not only our providers, but certainly our patients as well.
It's a very educational time. I think that there's a lot of information and lack of information. So anything we can do to help policymakers and their staff understand the real world implications beyond just balance sheets is really our task right now.
Yeah, because these are people's lives are at stake. It's not just a number on a piece of paper. So Lennie, you've certainly inspired me to try to do something. What should listeners do to try to get involved and learn more about these situations?
Absolutely. So first of all, if you're looking for more information like this, one of the things we've implemented this year, because there's been a huge rise in the request for information, is we're doing a bi-weekly advocacy update where basically I distill all of the news of the week into what's actually impacting rheumatology. This can be found in our ACR at Work newsletter. But if you don't subscribe to the newsletter or you've missed a week or you just want to see all of the back issues, they're available at rheumatology.org/advocacy news. So that's our advocacy news page. And like I said, every single issue of our advocacy update is available there in perpetuity. So you can search old issues. You can search for Medicaid. You can search for PBMs, any of those things that interest you, biosimilars. So anything that's impacting you, you can go find there. We are currently on X at ACR Room DC. We're not updating there as much, but mainly just because we're very, very busy. And we're probably going to start.
I can imagine.
We're really looking to kind of branch out more, maybe in LinkedIn or Blue Sky. So stay tuned. But definitely join us for our Convergence Advocacy session. That's going to be Tuesday, October 28th at 8 a.m. So that's going to be a full hour. Actually, I think it might be 90 minutes. And it'll be me, but it'll also be our state advocacy update. So you can find out what's going on in your state. Obviously, RoomPack is a huge, important thing that we do, and that comes with its own updates. So that's roompack.org again. But again, our letters to policymakers page is incredibly informative and full of all of the things that we're doing all of the time. We've endorsed 9 bills in Congress so far this year. We've sent 22 letters to Congress and the administration. Wow. We've had a board member testify in front of Ways and Means. We've co-hosted a Hill briefing with the Arthritis Foundation. We've done almost 50 coalition meetings. So it's been quite a kickoff for this Congress and this administration. And we're just going to keep working really hard. So we want you guys to know all of the things that we're doing. And if there's ways in which we can conduct that information to you that we're not doing, certainly let us know. Oh, the other thing that we have now is kind of an open forum. We were getting a lot more emails, and I think that conversation is much more productive. So if you go to the About Advocacy page, you can register to just get some time on our calendar. And by our, I mean the whole team. So depending on what issue you want to talk about, we'll just put you with the correct, most appropriate team member, whether it be a private payer advocate, because we do have a person on our team that just does advocacy with private payers, or our state team member, Joseph, or our regulatory team member. But we can put time on their calendar directly for you to just chat with them over Zoom and talk about whatever issue is concerning you or you have questions about. I mean, obviously you can still send us emails, but so we have those, we're calling them advocacy office hours, but you can sign up for those so that you can just chat with anybody on the team about the issues that are concerning you.
Awesome. Lennie, this has been really enlightening, and it certainly sounds like, we're all going through various very challenging times, and I'm so happy to have you there. You have your finger on the pulse, you know exactly what's going on in DC, and you're helping, us in the ACR and our patients and our members, make sure that we have the tools so that we can, care for patients, because at the end of the day, that's what it's all about. Thank you so much for your time, Lennie. Keep up the awesome work.
Thank you so much.
What a powerful discussion with Lennie on the complex challenges that faces the rheumatology community. From the need to reform Medicare reimbursement to the fight against the unchecked power of PBMs and the battle to restore critical research funding, it's clear that advocacy is more vital than ever. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, please advocate for your patient and our profession. And of course, stay healthy.